Welcome. In this session, we'll be discussing about primary open-angle glaucoma. We have discussed about IOP measurement techniques, gonioscopy techniques and findings, optic nerve head changes, visual field changes, and OCT changes characteristic of glaucoma in their respective sessions previously. In this session, we'll be discussing the clinical profile, differential diagnosis, and management of primary open-angle glaucoma. Primary open-angle glaucoma is defined as a progressive optic neuropathy with characteristic optic disc changes, characteristic and reproducible visual field defects which correspond to these optic disc changes, open angles on gonioscopy, and raised intraocular pressure for no clinically apparent reason. So as we have discussed previously, glaucoma is basically an optic neuropathy with optic disc and visual field changes. And in primary open-angle glaucoma, the angles are open and the intraocular pressure is raised, although we cannot find any reason for the raised intraocular pressure. The rise in IOP occurs due to increased resistance of drainage through the trabecular meshwork because of deposition of extracellular material in trabecular beams and deposition of plaque-like materials in the juxtacanalicular meshwork adjacent to the Schlemm's canal. There is increased actin cross-linking within trabeculocytes in primary open-angle glaucoma as well as reduction in the number of these trabeculocytes. And it is said that because of the raised intraocular pressure, there is deformation of the lamina cribrosa leading to damage to the axons of the retinal ganglion cells followed by death of the retinal ganglion cells. In a patient with primary open-angle glaucoma or suspected to have primary open-angle glaucoma, certain features in the history are important. In the ocular history, we have to find out about any previous episode of trauma, steroid use, and refractive surgery. In systemic history, we have to find out about any previous systemic steroid use, sleep apnea, migraine, Raynaud's phenomena, thyroid diseases, diabetes, and hypertension or hypotension. We have to also inquire about asthma and cardiac disease because presence of these conditions have implications in the choice of the drug we select to lower intraocular pressure in these patients. Presence of family history of glaucoma increases the risk of development of glaucoma 10 times as we have previously discussed. And in the treatment history, we have to inquire about any previous IOP recordings, visual field and OCT reports, and about any previous glaucoma medications prescribed and taken by the patient. Primary open-angle glaucoma is insidious in onset and slowly progressive and is asymptomatic until loss of central visual acuity occurs very late in the disease process. And because of its largely asymptomatic nature, diagnosis of glaucoma occurs during a routine clinical visit or when central visual acuity has been irreversibly lost in the very late stages of glaucoma. And this is why glaucoma is popularly known as a silent killer of sight. Primary open-angle glaucoma is bilateral but can be asymmetric. And as per definition, since it is primary, there should be absence of contributing ocular comorbidities such as pigment dispersion, pseudoexfoliation, neovascularization, and uveitis. As we have mentioned in the definition of primary open-angle glaucoma, signs of primary open-angle glaucoma include characteristic optic nerve head and retinal nerve fiber layer changes, characteristic patterns of visual field loss, raised intraocular pressure, and open angles on gonioscopy. It is the detection of characteristic optic nerve head changes during routine ophthalmoscopic examination which leads us to suspect and then diagnose glaucoma. And as we have mentioned in previous sessions, the structural optic nerve head changes usually precede the functional visual field defects. And among the structural changes, it has been seen that in primary open-angle glaucoma, retinal nerve fiber layer changes may precede optic nerve head changes. The characteristic pattern of visual field loss in primary open-angle glaucoma, the most common of which are nasal step and arcuate defect, should be reproducible in sequential visual field testing and should correlate with the optic nerve head changes. By definition, intraocular pressure in primary open-angle glaucoma should be above 21 millimeters of mercury, and on gonioscopy, open angles are characteristic of primary open-angle glaucoma. Even if we find open angles on gonioscopy at the initial visit, gonioscopy should be repeated at intervals to rule out narrowing of angles with age-related increase in the anteroposterior thickness of the crystalline lens. Gonioscopy is also indicated during follow-up when anterior chamber appears shallower following laser procedures in the angle such as laser trabeculoplasty, and when intraocular pressure during follow-up is found to have been increased. In the differential diagnosis of primary open-angle glaucoma, we have secondary glaucoma, the causes of which has been listed here and which will be discussed in subsequent sessions. Non-glaucomatous optic neuropathies and chorioretinal lesions having visual field defects mimicking glaucomatous visual field defects. Atypical clinical features which suggest a non-glaucomatous optic neuropathy include younger age of onset, unilateral disease, loss of central visual acuity early in the disease, dyschromatopsia, relative afferent pupillary defect, pallor of neuroretinal rim, and visual field defects not respecting horizontal meridian and not consistent with optic nerve changes. Natural history of primary open-angle glaucoma can be divided into 4 stages: a pre-perimetric stage, a threshold or conversion stage, a critical stage, and a stage of blindness. In the pre-perimetric stage, although characteristic structural features of glaucoma can be found, characteristic functional features of glaucoma cannot be detected, and so it is said that structural changes in glaucoma precede functional changes. So in pre-perimetric stage of primary open-angle glaucoma, no characteristic glaucomatous visual field defects are found on white standard automated perimetry. Non-specific changes such as enlarged blind spot, isopter shrinkage, and fluctuations in regional sensitivity may be found in the pre-perimetric stage. We have discussed these terms in the session on perimetry. As we have mentioned, characteristic structural changes in the optic nerve head, the retinal nerve fiber layer, and the macular ganglion cell layer can be found in the pre-perimetric stage either clinically or on OCT. Although visual field defects are not found on standard white-on-white perimetry, psychophysical perimetry tests may show abnormalities in the pre-perimetric stage, and we have discussed psychophysical perimetry in a previous session. In the threshold or conversion stage, reproducible and characteristic glaucomatous visual field defects start to appear on white standard automated perimetry, and they are typically in the areas of the nasal step and arcuate defect. By the time this stage occurs, it is said that as many as 50% of retinal ganglion cells and their axons may already be damaged. And before appearance of reproducible visual field defects, there can be a stage when visual field defects can be transient and disappear with treatment, only to reappear later. In the critical stage, reproducible visual field defects enlarge, become deeper and coalesce, threatening visual acuity, and it has been seen that upper hemispheric and bihemispheric defects confer a poor prognosis in primary open-angle glaucoma. Upper hemispheric defects result from destruction of all the inferior arcuate fibers, and upper hemispheric defects have been found to be more common because, as we have mentioned in earlier sessions, the inferior arcuate fibers are more prone to glaucomatous damage than superior arcuate fibers and are more prone to be near fixation. In this stage of blindness, the entire visual field is lost. We have discussed the risk factors of glaucoma in the session on epidemiology, but we will be discussing them once more in this session. The most important risk factor for glaucoma or primary open-angle glaucoma is intraocular pressure. The mean IOP of a white population has been found to be 15.5 mm of mercury with a standard deviation of 2.6 mm of mercury. So two standard deviations on either side of the mean includes a range between 10 and 21 mm of mercury. Intraocular pressure is said to be a continuous risk factor for open-angle glaucoma because glaucoma can occur at an intraocular pressure much lower than the population maximum. And so there is no cutoff intraocular pressure which can reliably differentiate between normal individuals and individuals with glaucoma. But higher the intraocular pressure, higher is the risk of developing glaucoma. Diurnal variation of intraocular pressure in primary open-angle glaucoma is larger than the diurnal variation in normal individuals, and we have discussed about diurnal variation of intraocular pressure in the session on intraocular pressure. And 30 to 50% of open-angle glaucoma patients can have an intraocular pressure less than 22 millimeters of mercury, and these patients are said to be having normal tension glaucoma. By definition, primary open-angle glaucoma has a raised intraocular pressure, but we may fail to detect this raised intraocular pressure in primary open-angle glaucoma patients because of intermittent rise in intraocular pressure which occurs due to diurnal variation, and we must exclude other causes of intermittent raised intraocular pressure which we have mentioned in differential diagnosis. Inaccurate IOP measurement can also result in failure to detect a raised intraocular pressure, and inaccurate IOP measurement can be due to a thin cornea, a low scleral rigidity, uncalibrated device, and a poor technique of measurement. Thin cornea is a factor in Goldmann applanation tonometry, and low scleral rigidity is a factor in Schiot's tonometry. We may also fail to detect raised intraocular pressure because of normalization of a previously raised intraocular pressure due to use of ocular hypotensives. And previously raised IOP can also be due to other causes which we have mentioned in differential diagnosis. Blacks, Hispanics, and Asians are said to be at a higher risk of primary open-angle glaucoma than whites, and Japanese have a particularly high incidence of normal tension glaucoma among open-angle glaucoma patients. Older age is an independent risk factor for both development and progression of open-angle glaucoma, and there is an up to 10-fold increase in prevalence of glaucoma from the 5th to the 9th decade of life. And a family history of glaucoma is said to increase the risk of glaucoma up to 10-fold. In primary open-angle glaucoma, a large zone of peripapillary atrophy increases the risk of glaucoma progression. High myopia is a risk factor for glaucoma, and risk of primary open-angle glaucoma increases with increasing myopia. Myopia can also interfere with glaucoma diagnosis because of the occurrence of tilted discs and or posterior staphyloma with minification of the clinical appearance of optic disc, making it difficult to detect the glaucomatous changes of the optic nerve head. And in myopia, even without glaucoma, visual field changes can occur from retinal degeneration. And as we have discussed in the session on OCT, temporal displacement of both the superotemporal and inferotemporal RNFL bundles in myopia results in errors in sectoral RNFL analysis on OCT. As we have discussed in the previous session, ocular hypertension treatment study showed that a thinner central cornea is an independent risk factor for development of glaucoma, and a thinner central cornea has also been shown to be an independent risk factor for progression of glaucoma. And some studies show that patients with lower corneal hysteresis are prone to develop glaucoma. Several studies have shown that cerebrospinal fluid pressure is low in glaucoma patients, particularly in normal tension glaucoma patients. And it has been suggested that this low cerebrospinal fluid pressure leads to an increased translaminar pressure across the lamina cribrosa, increasing the stress on the lamina cribrosa. The translaminar pressure being the difference between the intraocular pressure and the cerebrospinal fluid pressure posterior to the lamina. It is well known that long-term corticosteroid use in any form leads to an increase of glaucoma by elevating intraocular pressure, and this is called steroid-induced glaucoma and is said to be a form of secondary glaucoma. But primary open-angle glaucoma patients show steroid responsiveness, which is rise in intraocular pressure following use of topical steroids. And the degree of steroid responsiveness has been classified as intermediate and high responders who have a rise in intraocular pressure of more than 5 millimeters of mercury and more than 15 millimeters of mercury respectively after 3 to 6 weeks of using topical steroids 3 to 4 times daily. 35% of normal population are intermediate responders and only 5% of normal population are high responders. But 90% of primary open-angle glaucoma patients have been shown to be high responders. And this must be kept in mind when these patients require topical steroids for ocular comorbidities. The association of primary open-angle glaucoma with blood pressure abnormalities and diabetes mellitus is equivocal. Some studies suggest that significant increase in the rates of primary open-angle glaucoma occurred with diastolic blood pressures less than 50 millimeters of mercury, leading to a low ocular perfusion pressure. And it is known that nocturnal hypotension contributes to glaucoma but is more important as a risk factor in normal tension glaucoma. However, there is no evidence to suggest that raising the blood pressure in this situation will reduce the risk of progression of glaucoma. Other studies have suggested that higher systolic and diastolic blood pressure are associated with higher intraocular pressure but not with increased prevalence of glaucoma. And some have also found that systemic hypertension lowers the risk of glaucoma in younger individuals but increases the risk of glaucoma in older individuals. Similarly, only some studies suggest an association of diabetes mellitus with primary open-angle glaucoma, which other studies have rejected. And there are studies which have shown that diabetes is associated with raised intraocular pressure but not with increased prevalence of glaucoma. Other reported risk factors for primary open-angle glaucoma include sleep apnea, migraine headaches, Raynaud phenomena, and thyroid disorders, the first three being more well known as risk factors of normal tension glaucoma, which we will be discussing in the next session. And no definite association of primary open-angle glaucoma with smoking, alcohol, or intake of coffee has been found. Lowering of intraocular pressure is the only treatment available till date which can arrest or decelerate progression of glaucoma, including primary open-angle glaucoma, but lowering of intraocular pressure cannot reverse the disease process, which is important to understand and remember. Lowering of intraocular pressure can be done with medications, laser therapy, and incisional surgery. Incisional surgery can be beneficial as an initial treatment in advanced glaucoma. We will be discussing the modalities later in their respective sessions, and several tests must be repeated periodically in established glaucoma patients to detect progression, and they include optic disc stereophotography, visual field testing, and OCT of the optic nerve, retinal nerve fiber layer, and macula. Repeat visual field testing should ideally be done on the same machine with the same testing algorithm and testing strategy in order to detect progression. And even if the initial diagnosis is open-angle glaucoma, repeat gonioscopy should be done at intervals during follow-up, as over the years the angle tends to narrow with increasing anteroposterior thickness of the crystalline lens. At initiation of treatment, the clinician needs to gauge a target pressure to which the baseline intraocular pressure needs to be reduced to based on severity of the disease and presence of risk factors for progression, but no formula exists to calculate the target pressure. The target pressure usually varies between 20% to 50% reduction of the baseline intraocular pressure. Following achievement of the target intraocular pressure, the intraocular pressure needs monitoring on long-term follow-up to ensure that the intraocular pressure stays at target pressure levels, and visual field and OCT tests must ensure that there is no further progression of glaucoma with intraocular pressure at the target level. On the other hand, if there is evidence of further progression after achievement of the initially determined target intraocular pressure, the target intraocular pressure needs to be revised and a lower target intraocular pressure needs to be determined and achieved, at which long-term monitoring with visual field and OCT testing confirms stability of the disease process without further progression. Glaucoma therapy being chronic and lifelong, compliance to therapy is a significant issue, and non-compliance has been reported to be as high as 30 to 80% among all treated patients. Causes of non-compliance include, on the one hand, asymptomatic nature of the disease, and on the other hand, side effects and cost of drugs used to treat the disease. And because of this, patient education about future risk of blindness from glaucoma is essential to increase compliance to therapy. Patients with severe visual field restriction and or loss of visual acuity can be benefited by low vision rehabilitation services, and these include optimizing lighting, enhancing contrast, reducing glare, magnification of target, and vision substitution. Fortunately, a large proportion of adequately treated glaucoma patients retain central visual acuity throughout their entire lives. And one study has found that among treated patients, 13% become unilaterally blind and 4% become bilaterally blind after 20 years of treatment. To recap the salient points, primary open-angle glaucoma is a progressive optic neuropathy with characteristic optic nerve head and visual field changes, with open anterior chamber angles and raised intraocular pressure, but without any clinically apparent reason for the raised intraocular pressure. Intraocular pressure increases due to increased resistance to aqueous outflow through the trabecular meshwork. Raised intraocular pressure is said to be the main causative factor in the primary pathology of glaucoma, the deformation of lamina cribrosa, which leads to damage and death of the retinal ganglion cells whose axons pass through the lamina cribrosa. Primary open-angle glaucoma is typically insidious in onset, bilateral but can be asymmetric, slowly progressive, and asymptomatic till late in the disease. Natural history of primary open-angle glaucoma include a pre-perimetric stage before visual field defects become apparent, a threshold stage when visual field defects start to appear, a critical stage with large and consistent visual field defects threatening fixation, and a stage of blindness. Consistent risk factors for primary open-angle glaucoma, which have been reported in almost all studies, include raised intraocular pressure, increased age, race, thin central cornea, family history, myopia, low corneal hysteresis, and low CSF pressure. Risk factors which have been found in some studies but not all include raised or low blood pressure, diabetes mellitus, hypothyroidism, migraine, Raynaud's phenomena, and sleep apnea. Differential diagnosis of primary open-angle glaucoma include secondary open-angle glaucoma, non-glaucomatous optic neuropathies, and chorioretinopathies causing visual field defects resembling visual field defects of glaucoma. Lowering the intraocular pressure is the only treatment available till date to arrest or decelerate the disease process, and this can be done by medical, laser, or surgical therapies. At the initiation of therapy, a target intraocular pressure has to be decided on. During follow-up, periodic monitoring with IOP measurement, gonioscopy, optic nerve head photography, visual field testing, and OCT is essential to determine whether the target pressure is achieved and whether this achieved target pressure is sufficient to arrest progression. Repeat gonioscopy on follow-up is important in primary open-angle glaucoma, as over the years the angle tends to narrow with increasing anteroposterior thickness of the crystalline lens. Compliance to therapy is a very significant issue in glaucoma therapy because of the asymptomatic nature of the disease and side effects and cost of the drugs used to treat the disease. Fortunately, a large proportion of adequately treated primary open-angle glaucoma patients retain central visual acuity throughout their entire lifetime. Thank you for listening.